You are listening to the Movement Therapy Podcast.
Hello and welcome back to another episode of the Movement Therapy Podcast with Zoe and Ethan.
Hello, welcome.
Eth, how are you today?
I'm good, Zoe. How are you?
I'm very well, thanks for asking.
Excellent.
Now, what are we talking about today?
We're going to go straight into chronic low back pain. So last week we were talking acute. Now we're talking chronic, long-term stuff.
Amazing. Now, tell me what we're going to be talking about.
All right. So, let's review from last week.
Yeah.
Last episode we talked about the acute low back pain. And essentially we sort of spelled out when is a good idea to present to hospital.
Yes.
What are the different types of sort of nasty and sinister pathologies and symptoms to look out for to then, access further medical investigation.
Yes.
Again, by all means, wasn't a definitive list of do's and don'ts, wasn't a 0 and 1. It's very grey area.
Yeah.
But we just gave you an outline as to sort of the main things to look for those symptoms. And then what can we do at the clinic to assess and treat acute low back pain? So there's a few sort of overviews for last week's episode.
Yeah.
Head back and listen to that one if you like. But today, we're going to do this over two parts, I think, because there's a lot to cover.
Yeah.
And hopefully we get a look at sort of a little bit of everything. Again, I want to emphasize that this is just a general discussion about chronic pain. It's not definitive advice or what personally you should do, obviously because each case is so individualized and everyone has their own story and their own symptoms, etc. And it's in no way prescriptive.
Yeah. Use this as a little bit of a guide, not
Absolutely.
as the rule book.
Exactly. We don't want to tell you how to live your life. You do that. If you've got any questions, please come on in and we can assess you properly and give you the right advice as an individual level. So I want to emphasize that before we start. But let's get stuck into it.
Let's do it.
What is chronic low back pain?
Back pain that lasts, I think I can do this, that
Go.
lasts for a period of longer than 6 months.
Oh, absolutely nailed it.
Oh, I'm so good.
So we talked acute was that sort of 3-month mark, subacute probably a little bit longer, and then chronic pain, we're hitting the 6-month mark. I sort of also want to think about, we talked about last week the subacute pain.
Yeah.
So the acute flare-up of a chronic issue.
Yes.
So that thinking about the pain's been there or the issue has been there for a long time.
Yeah.
So these sort of things, they might not be obvious or painful, but they're still there.
Yeah.
And they're still causing that potential movement issue. These can be thought of as chronic issues, not necessarily chronic pain.
Mm-hmm.
But essentially, pain that's lasted more than 6 months. That's what we're going for.
That's what it is.
Now, I get a lot of people into the clinic coming to me and saying, oh, I've had this, dicky right shoulder for 20 years and that's fine. That's me. That's normal.
Are you talking about when I come in and see you?
Not specifically you, although we can...
If the shoe fits.
Well, I mean...
Anyway, back to it.
But most of these things are coming back to you, Zoe.
I know.
Things to do. It's a little guide for you.
It's not the rule book.
It's not the rule book. It's just a guide. I don't want to tell you how to live your life. But I get a lot of people coming in and saying they've got these pains and that they're normal.
Yeah.
And they're normal for them and they've had them for years and that sort of thing. And I want to put a little disclaimer out there that pain is not normal. It is a signal.
Yeah.
So we need to respect it and we need to be able to do something about it. Now, obviously, there's many conditions that result in chronic pain.
Yeah.
I'm talking autoimmune conditions, specific neurological issues and those sort of things. That's I'm not talking about those abnormal sort of conditions and syndromes.
Yeah.
What I'm talking about is sort of most of the general population. And again, we can go into those specific conditions if we need to in future episodes. But for now, overall, I don't want you to think about pain as being normal and something you should live with, especially in the older adult.
Yeah.
So we don't want to be going, because you're 60, you should have low back pain. That's definitely not the case. And we know that we've got a lot of the elderly, not that 60 is elderly. Just because you are a certain age does not mean or qualify you to be in pain.
Yeah.
We have a lot of, I was racing in one of the triathlons a couple of years ago and there was a 92-year-old, I think, in the field and he was killing it.
Oh, but that's very incredible.
He was killing it. So, age does not qualify you to have pain. Yeah, I mean, I treat young people with pain. I treat old people with pain. I treat a lot of people with pain. So age is not a determinant factor at this stage. Pain's a signal. So the brain's trying to communicate with you, whether it's trying to get you to safety or telling you have sort of inefficient movement patterns, or you're exceeding your, what we call the functional threshold for a certain activity. And I'll explain that later, but it's a signal. So we've got to do something about it.
Yeah. Bare minimum, acknowledge it, find out why.
Exactly. Yeah. And that's the thing. Come in for the assessment. I can't tell you why you have pain in the podcast, because so many people have pain for so many different reasons. And I could get 50 people lined up with the same lower back pain, but they could be all caused from a different factor.
Very individual.
It's very individual. We need a specific individual assessment to figure it out. But what I'm trying to trying to get across is that there is the possibility that you shouldn't be in pain.
Yes. And even, you know how at the Oscars they have the little red flashing light that tells people when to wrap it up?
Oh, I didn't know they did that. Is that a thing?
Yeah, and they just start playing the music. I might need one of them.
Yeah, because I'll just keep going.
I think so.
Okay.
Not in an offensive way. Like how age isn't a bad thing. Talking isn't a bad thing.
Okay. But I want to go into sort of more about what chronic pain is and how to sort of explain it, I guess. But
yeah.
I like my analogies.
Yes.
So, and I have used an analogy. I think last week we talked about the fire alarm analogy.
Yes.
So the danger of the fire alarm goes off.
Yeah.
So I want to talk about this in 3 different scenarios. Yeah. So I want you to kind of think of chronic pain as the fire alarm in the house.
Okay.
So in a normal scenario, in a general scenario, there's a fire in the floor of the house. The smoke travels to the fire alarm. That's the signal. The fire alarm interprets that signal and then goes off, alerting the people in the house to the fire. The people will either try to put out the fire or call the fire brigade to come and help.
Yeah.
I.e., the action to put out the fire stops the alarm.
Yeah.
That's the normal scenario.
Yeah.
Alarm stops. Everyone's fine. We go back into the house.
Yeah.
Cool?
Cool.
This is the chronic pain scenario.
Okay.
So let's assume the normal scenario continues to happen.
Yeah.
So we keep getting it every hour. Sort of, we get the fire alarm is going off. Now, suddenly, that fire alarm is actually getting sensitive to the signal of the smoke.
Yeah.
Now, I just want to clarify, this actually doesn't happen in real life. Fire alarms can't learn. It's not AI yet. That's a scary thought. But this is just a scenario. So the fire alarm is sort of learning, and suddenly someone in the house lights a tiny little tea light and puts it on the floor, and then the fire alarm goes off. Exactly the same reaction.
Yeah.
So they put out the candle and try to turn the fire alarm off, but they can't, and it keeps going.
Okay.
Until suddenly everyone in the house gets sick of it and just leaves it alone. It just lets it ring out.
Becomes part of the furniture.
Becomes part of the furniture because no one can do anything about it.
Yeah.
And no one wants to. It's annoying. So now it becomes just part of their normal house and routine. It's like, oh yeah, that's cool. That's the fire alarm.
The fire alarm goes off. You'll get used to it.
That's the fire alarm. Cool. Now that's the overall chronic pain scenario.
Yeah.
Now I want to talk about the fixing the symptoms scenario.
Fixing the symptoms scenario.
Okay. So, i.e., not knowing the cause.
Yeah. Is it the tea light?
Just treating where it hurts. So
I'm really drawn into the
I know. I had a lot of time on my hands with this one. So I get a lot of people, like I was saying, coming into me saying their back's been sore for ages. They've been to so many physios. And when I ask what the physios do, I get a lot of the same response. I get a lot of, oh yeah, massage my back, a bit of dry needling. He told me to stretch my hip flexors and strengthen my glutes. And then I ask them, well, have you been diagnosed with anything? Did they find a cause? Did they find a functional diagnosis? And a lot of the time people say no, they don't have a diagnosis. They don't have a cause.
So they're kind of putting out the fire without seeing why it's starting. Yeah.
So, actually the opposite. So let's go back to the fire alarm. Let's go with the tea light scenario, right? The chronic pain scenario. So you've lit the tea light and it set the fire alarm off. Now, all you try to do is turn the fire alarm off.
Yeah, instead of not turning off.
Putting out
the tea light.
Yes, instead of putting out the tea light. So after a few minutes or a few hours, the fire alarm goes back on because the stimulus still exists as the tea light.
Yeah.
And all you try to do is keep turning that fire alarm off, keep turning that fire alarm off, keep doing your massage, keep doing your dry needling. I'm not saying that's not going to help. Potentially it will, but you're not changing the stimulus. So the problem isn't the fire alarm. The alarm is the response to that signal. It's just trying to do its job. It doesn't know any different. It's going, there's smoke, there's a signal, I'm going to go off. The problem is the signal being sent to it from the candle.
Yeah.
So what we need to do is find the candle.
Yeah.
And blow it out. Problem gone, no signal, no fire alarm response. You don't have to keep turning off the fire alarm.
Success.
So our job, again, is to assess properly, find that candle and get rid of the stimulus.
Yeah.
Now, the problem can potentially worsen if suddenly the fire alarm goes off for a completely random signal instead of the actual smoke from that tea light. For example, a fire alarm in the house going off from steam.
2-minute noodle steam. Someone's made some 2-minute noodles and the steam's set.
Or like the bathroom, steam. You open the door and then it comes out. The fire alarm shouldn't go off with that unless it's a heat detector.
Yes.
It should be a smoke detector.
Yes.
Right? So this is, the signal can be interpreted heaps of different ways, and the brain is a very complex organ that can do that. So this is where it can be a bit tricky, and where chronic pain can last a long time, because we might be trying to find the candle, but the problem might not be a candle. The problem might be the steam coming out of the bathroom. Anyway, that is that red light on again?
No, not yet.
Not yet?
I think I need to turn it off myself as well.
No, I think we're going well. I think does that simplify, or does that make it way worse?
No, I think that makes sense.
Cool.
It's not always about what is presenting, like what pain you've got, but why.
Exactly.
And that why might be one thing, or it might be another thing.
And this is where it becomes individual.
Yeah.
So 50 people lined up with back pain, they're not going to have the same why.
No.
So we've got to ask, why do you have that pain, right? What caused it? This is why I'm interested in the shoulder surgery you had when you were 15.
Yeah.
Because that's changed your anatomy. As soon as you change something, you're altering the signal to the brain in any position.
Yeah.
So then suddenly you start to become, a triathlete or a tennis player or something that you're not used to, and suddenly the signal amplifies and it gets worse, and then suddenly your fire alarm sensitizes, and then you're drawn to the back pain because it hurts, fair enough, but you're not necessarily going to fix the problem. Yeah. Right? I get a lot of reoccurring patients that sort of, get the symptom relief treatment and then stop coming. Yeah. Fair enough, because they're not in pain anymore. But then it comes back.
Oh.
It comes back in a few months, 6 months, a year, but it's always coming back. It's like, I have this on and off pain. There's your acute on chronic pattern. Yeah. Cool. So we want to block that. I want to change it. I want to change the signal. And you can only change something by changing something.
Yes.
There's a profound quote for you.
There you go. Quote of the day.
I don't know if that is an actual quote, but I'm
going to say someone's said it before.
Okay. So we've got this information. Now, how do we treat chronic low back pain?
Good question.
It's kind of a trick question because we can't treat it. We've got to assess it.
Oh, okay.
So we've got to, again, as the theme of the last couple of episodes is we have to find the candle, find the stimulus, find the thing. So we need to establish the cause of the pain and the trigger of the signal. Like I said, the previous medical history is so important, and not just musculoskeletal history. So I want to know medical history, especially COVID started to mix things up a little bit. Yeah. Long COVID started to mess things up a little bit. So that can have a issue with pain. Even if the common cold can influence pain, any virus or viral load can influence pain. Yeah. So it does matter, those sort of things, even though, if your therapist asks you, any previous medical history. I did have one story. There was a guy, he came in for his shoulder, I believe, a few years ago, and I asked him, routinely, any other injuries or surgeries? And I remember specifically saying the word surgeries. And he was saying, no, all good. Rolled my ankles a couple of times, but no dramas. And I was dealing with his shoulder, so we let that one slide. Yeah. And then got up, took his shirt off to assess the shoulder, turned him around. There was a huge scar running down his spine.
Oh, hang on.
And I questioned it. I was sort of going, okay, is there a reason he hasn't told me about this? But I sort of going, hey mate, what's this scar for on your back? Oh, had a big fusion down. So that's where you essentially just join the spine together and block it from moving, often in response to chronic pain. We'll talk about that later. And neglected to sort of, but he said he thought that was ages ago.
Oh, I find sometimes that I forget as well.
Well, exactly. As human beings, we're very bad historians, and we often either forget or don't think it's relevant.
Yeah.
So normally, this is where the ability to build a rapport with your clients is so important, because then we can keep assessing. We're not going to arrive at a functional diagnosis or a proper diagnosis straight away.
No.
It's not going to be, this is what's causing your back pain. It might take a few sessions to get there. The longer it has occurred for, the harder it potentially is to find the cause.
Yeah.
But still is important.
Yes.
So it is important that you rolled your ankles 5 years ago, or that you had surgery as a teenager, or you suffer from a chronic medical condition. It matters that you've got endometriosis or an autoimmune disease.
Because you know what? As you said, unfortunately, the whole body is connected.
Unfortunately, everything is connected, head to foot. That song, head, shoulders, knees and toes,
Unfortunately, but also fortunately.
is very accurate, but very fortunately, because that would be weird if
You came in bits.
we came in bits. So health status also matters.
Yes.
Gut health, oral health, stress, the level of inflammation in the body. We'll go through this in a more deeper analysis
Yes.
later, probably in episode 2 of the chronic pain.
Mm-hmm.
But I want you to sort of start thinking about things that might influence pain, chronic pain, specifically back pain. Let's go back to the biomechanics and the movement side, because that's where we specialize in, obviously. Let's go back to the first year of life, Zoe.
Long time ago.
It's a long time ago, longer for some. That's the most important year for movement, development, and that kinesiology learning from the brain. The brain is getting so much stimulus, and pretty much all it's trying to do is stand up and walk.
Yeah.
Now, it's quite complicated because we can't just stand up and walk. It takes us about 12 months to be able to do that. So what the brain is doing is it's actually learning to stabilize parts of the body together, and eventually learning to do this contralateral, what we call contralateral patterning.
Yes.
So contralateral patterning is just normal walking. So if you think about walking, which is something weird, not many people have sort of needed to do that in their life unless you've injured your leg or something. So that means we move our opposite arm and leg at the same time. So if you take a step with your left leg forward, your right arm moves forward at the same time.
Yeah.
So that is more of a counterbalance thing as well. And it's why potentially your left ankle can influence your right shoulder because of these movement patterns. But anyway, that's getting more specific. It's another story. But what that first year of life is doing is teaching us how to stabilize our hips and shoulders together, as well as our trunk, which is that center of stability, which we all need for walking. So we need our hips and our shoulders for walking. Now, I want to put that in perspective. So I've got a client, 24-year-old female client that I've been treating for probably 6 years or so. Now, she first presented when I was a very young physio with severe low back pain. So this pain was debilitating. This client could not stand up from the floor when she had these flare-ups. They would happen, maybe once a week, once a fortnight, the really bad ones. But then at the rest of the times, she had sort of chronic pain, just resting there. Occasionally it would be sciatic pain down the leg, only on one side. And this was alarming as a really young physio. I was scared, right? I was going back to the acute pain episode and thinking, has this girl got a, malignant tumor in her spinal cord? Has she got a radiating bulging disc into a spinal canal? Does this need surgery? Yeah. And I'm thinking, oh, hang on, this is not a 60-year-old, that we have been taught back pain is normal for. This is a 24-year-old, young, fit, healthy, active. Now, she had MRIs. She went down the scan route. She was sent to a surgeon for a review. Now, luckily, there was nothing on the scan that the surgeon could fix. Which was very lucky in her case.
It's good.
But all I could do as a young physio at the time was treat the symptoms.
Yeah.
So I went to the treating the symptoms scenario, as we talked about a few minutes ago. And so that was the back pain, that was the nerve pain down the leg. And we did it for years.
Yeah.
And like I said, I've been treating it for a long time. And it did improve, but it was extremely slowly.
Yeah.
And personally, I was unsure about not what I was doing, but that this wasn't helping her.
Yeah.
Because we hadn't assessed her properly to find the cause.
Yeah.
Now, let's fast forward a few years. Obviously, I've learned a lot more. Now, the movement pattern-wise, if we go to pure movement, she has never been able to touch her toes,
Oh.
this girl. So, 24-year-old.
Yeah.
Right? And I want to put a little disclaimer in there. That is a very, very normal movement pattern that we should be able to do. We should be able to touch our toes with straight legs. Right? So that was a little bit of a flag for me to start with, to go, well, what has happened to enable her not to touch her toes? Now, otherwise she was fit, healthy, young girl. She did start CrossFit at a very young age. I think she was about 16 when she started CrossFit. Now, don't get me wrong, absolutely love CrossFit as a sport. I do not want to have this bias of physios hate CrossFit and all the rest of it. We absolutely don't hate CrossFit. It's a great sport. It's a challenging sport.
Yeah.
But it's a fantastic sport. So definitely don't have any bias against CrossFit. But I discovered for this client that her hips were significantly restricted in rotation.
Right.
So she couldn't twist. And she had sort of what we term a myofascial block in her posterior chain. So think about all the tissue and muscle on the back of her legs and spine. This was all restricted.
Okay.
So combine that with that was probably causing the inability for her to touch her toes.
Yeah.
When she was doing something like a deadlift, for example, and cleans and things that are very normal movements in CrossFit, she wasn't being able to do this. She couldn't do this to a good enough extent that allowed, safety.
Yeah. So she was having to alter the movement.
So she was having to alter. Yeah. She was compensating.
Yeah.
Yeah. Which she did really well until she couldn't anymore.
Yeah.
So I use the analogy of a domino. So if you picture a domino and if you do a compensation or a poor movement pattern, you're putting one domino on the floor.
Yeah.
Which is fine. One domino on the floor, no problem. And you do that again and you put another domino on top of that domino. And then that's fine, 2 dominoes. You keep doing it. You keep doing it. You keep stacking these dominoes. Now that might be fine for 2, 3 years, 4 years, and you've got 200 dominoes stacked on there. That's fine. Then something happens and you put that 201st or 502nd or however many dominoes it takes for the whole tower to fall over. And then everyone assumes it's that last domino that you put on top that is the cause of all of this.
Yeah.
But it's actually that first domino.
Yeah.
What is the first one you laid down? Fix that and the tower doesn't grow anymore. So we did some more digging. We got primal in these movement patterns, and I was convinced that she wasn't able to do more of these movement patterns. And we actually found out that she never crawled as a baby.
Oh.
So we went back, we asked mum, we got the records out, and she went straight to walking.
So she went from laying on the floor.
So essentially laying on the floor.
Go.
Yep.
Ah.
She did some rolling.
Okay.
But she could never crawl.
Interesting.
Right? Now, crawling is such an important stage because that's the first introduction to contralateral patterning.
Yes.
So rolling over is what we call an ipsilateral pattern. So that relies on the same side. So the left leg working with the left arm, not the left leg working with the right arm.
Yes.
So now the brain doesn't actually or has never been taught this contralateral patterning.
Yeah.
So that has never been programmed.
Okay.
Now, you can never unlearn a movement pattern that has been taught to you.
Right.
Let's let that sink in a little bit because that's quite powerful, good or bad. You can never unlearn it. Once it's in there, it's in there. It just depends where it is in there and how well you are able to replicate it. And we'll discuss developmental sequencing probably in a future episode, but for now, I want you to stress that she's never crawled, this patient.
Okay.
Fast forward a few months after we discovered this, and she got a stress fracture in her foot. So keep questioning things for this client. Now, I went back to the movement pattern and go, hang on, running is a contralateral pattern.
It is.
So at the moment now she's challenging because she wanted to start training for a marathon. So she started running more.
Right.
So she was continually running and stacking these dominoes every time she went for a run. But that's challenging a contralateral patterning, which she's never taught herself before.
Yeah.
Yeah, she's been able to walk and she's been able to, function as a human being and work and all the rest of it. Yeah. But when she challenges that system, so when she starts pushing the envelope as to what she's capable of, that's when things start to break down a little bit. And it's broken down in a slow development of a stress fracture.
Yes.
Now, we started spotting the candle. So we're starting to see the candle of her inability to understand and stabilize and execute a contralateral pattern, which has prevented hip movement in that direction.
Yeah.
And has led to the spine needing to work harder and in ways that it doesn't want to or isn't designed to move. Yeah. So eventually that compensation is going to stack enough dominoes on that tower and it will eventually fall over and lead towards this pain.
Yeah.
Now, if we kept, reverse a few years, if we kept treating those symptoms and just kept doing symptom relief, which might have been great short-term wise, it's not going to fix the problem.
Yeah.
And this client would have continued to have back pain. Now, at the moment, back pain doesn't exist for her anymore.
Woohoo.
We're dealing with the stress fracture at the moment, but we still have to treat the pattern.
Yeah.
Now, at being 24, she's had, say, 23 years of moving without this pattern.
Yeah.
It's not going to come back overnight.
No, it's very ingrained.
Yeah. So we need to not unteach movement patterns, but we need to reteach the movement pattern that was missed so many years ago. Mm-hmm. And then we need to challenge that in a safe environment to be able to load and strengthen that system.
Yeah.
So that was it's a really good example of how A, timeframes, and we'll talk about that in the next issue. B, just finding that cause and getting away from treating symptoms.
Yeah.
I think we're going to leave it there for our first part of this chronic pain episode. Zoe?
Cool.
There's a bit involved in that.
There is a bit involved in that. I think it's all quite important.
Definitely important. Definitely interesting. So yeah, we'll stay tuned for episode 2, and we'll keep going onto the on this chronic back pain little pathway. So thank you, Zoe, for staying with me.
Thank you, Ethan.
And thank you all for listening. Again, love any feedback. So please email. You can email me at ethan.miles@movementtherapy.net.au. If you have any questions at all, pop in, see Zoe at reception, or find us on Instagram at Movement Therapy AUS or online at movementtherapy.net.au. Thanks, Zoe. We will talk to you soon.